So, welcome to RADR 2335 seminar, Advanced Procedures, GI Studies. So, our digestive tract. Our digestive tract uh, includes accessory organs, which is the liver, the gallbladder, the pancreas, and the spleen. So, the liver, pancreas, the spleen, and then in the liver is the gallbladder. Okay? So, three primary functions of the digestive system: ingestion or digestion. So, oral cavity, ingestion, pharynx, esophagus, ingestion to the stomach, which starts digestion into the small intestine, absorption within the small intestine, and then elimination in the large intestine. So those are the three primary functions. Abdominal quadrants, we've talked about this before, where we're going to split it into fours. So we have the right upper quadrant, the left upper quadrant, right lower quadrant, and left lower quadrant. Know what's in these quadrants so you can decipher when you're given a question of what might be in one of those quadrants. Okay, so the 9 regions, once again, instead of splitting it into 4, we have 9 now. So right hypochondriac, right here's the right hypochondriac. 2 is the epigastric, and then 3 is the left hypochondriac. So you have to know these as well for the right lumbar, the left lumbar, and then the umbilicus for number 5. You should know the right inguinal or right iliac, the left iliac, left inguinal, and then the pubic or the hypogastric. So know those as well as not only the 4 but the 9, what is mostly in them, what lies within them, and how to break a question apart if you're asked for something within the 9 regions when compared to the quadrants. So contraindications to BASO4 is a pre-surgical patient, a perforated or hollow viscus, and a large intestine obstruction. So barium is going to be a contraindication when we're looking at these 3 as possibility. So definitely take a good history, know what your patient is there for, know what could be a contraindication. A lot of times your patient is going to show up with an order, and by the history that you ask them, your order may be changed either by the doctor or the radiologist, depending on what is going on and what they're wanting to see. Okay, so make sure that you take a good history. Contraindication to water-soluble iodinated contrast media are young or dehydrated patients or somebody that is sensitive to iodine. So if you can't use barium, you may have to go to iodinated contrast water-soluble, but then still you need to know a history, and then you need to know, are you dealing with young or an older dehydrated patient or somebody with sensitive to iodine. Common radiographic procedures, we have an esophagram or barium swallow. Okay, so you should know by now that they're referred to one or the other, either a barium swallow or esophagram. And then you have your upper GI series. The purpose of an esophagram is to study the form and the function of the pharynx and the esophagus. So you're going to follow that barium all the way down until it empties into the stomach, sometimes from the stomach to the through the pylorus and into the duodenal bulb, just depending on the radiologist. But your esophagram is a form of the esophagus and the function. Is it all working? Upper GI series. Purpose of an upper GI series, you're studying the form and function of the distal esophagus, stomach, and duodenum. So distal esophagus into the stomach, through the pylorus, into the duodenum, the duodenal bulb, and then into the small intestine until it gets to the sphincter at the large intestine. Okay, so you're following it all the way through the form, the function, a lot of times the time it takes to get from the stomach all the way through the small intestine. Esophagus and stomach filled with barium is what you're seeing here. So proximal esophagus, distal esophagus to the stomach. You're seeing your oropharynx up here as they swallow, and it squeezes and pushes it down to the stomach. Peristaltic constricture in the mid-esophagus is what you're seeing here. So that is form and function of the esophagus. That's what you're looking for. The barium-filled stomach and duodenum. So you have the stomach. You can see the fundus with the gas in it, the greater curvature, the lesser curvature, the pyloric antrum, the pyloric canal into the duodenal bulb, and then into the descending duodenum. Okay, so sometimes you'll have radiologists that will follow the esophagus all the way down to the stomach, and then as it empties out of the stomach, and then that's going to end the esophagram. So supine, remember to review all of this as far as where is the barium. When a patient is supine, where is the barium? If a patient is in a prone position, RAO, where is the barium? Okay, so RAO, you're seeing that air is in the fundus, barium is in the distal stomach, and pylorus and duodenum. When a patient is supine, you're seeing that the barium is mostly in the fundus. So understand your patient position, understand where the barium and the air is going to be. So air barium distribution, we're seeing supine, barium is in the fundus, okay? Because that stomach lays across the top and kind of comes down on this left side. So that's where the barium is going to collect. If a patient is prone, barium is going to be in the distal portion of the stomach. You're going to be able to see the greater curvature, lesser curvature. You're going to see air in the fundus because that fundus sits more posterior, so that's where the air is going to go. A patient being erect, you're going to see a distinct air fluid line, okay? This one is not a distinct line, and this is not a distinct line here either. So this can also tell you, no matter who is taking the image, if you look at it, you can tell if they were erect or if they were prone or supine, according to the air and the barium distribution. So right here for A and B, once again, we're looking at which is prone, which is supine, compare with the previous drawings. Make sure you review this and you understand it. So also, here we go with our body habitus. So hypersthenic, sthenic, and hyposthenic or asthenic. Everything lays within the body different. So hypersthenic, the stomach is high and horizontal. Here we have a sthenic patient where the stomach kind of makes an L where the fundus is high, and then your the main portion of your stomach, the body of your stomach, and the distal portion kind of come across around L1, L2. Hypersthenic is high around T11, T12. And then you have your hyposthenic, asthenic patient where the curve in your stomach, it'll make a J shape a lot of times. And the lower portion of your stomach, mid portion of your stomach is around L3, L4. So it sits really low in that patient like this, okay? So upper GI procedure, contrast media is required depending on what you're doing, what kind of contrast media you're going to use. It increases or decreases tissue density just depending on what you use. So here's your AP abdomen, and here is your PA upper GI. So PA, you're imaging this PA for an upper GI because everything that you're imaging is more anterior. So you want that closest to the image receptor, so that's why you're going to image that patient in a PA position. Fluoroscopy, you're able to view and record and evaluate the function and form in real time. You're seeing the motion of the anatomy. You're seeing them swallow. You're seeing it go through the esophagus, into the stomach, empty from the stomach, into the duodenum. Okay, so that's what we use fluoroscopy for. Radiolucent foreign bodies, you can use, I know that they've done before, they don't do it necessarily anymore, but cotton balls soaked in barium. Usually you're using barium pills. You may use different densities of food for a swallow function. So a lot of times some of this stuff isn't used anymore for just an esophagram, but keep in mind every place is different, and in your work experience you may run across some of this where they're giving them marshmallows followed by barium, or some barium pills to watch it go through the esophagus. Pathologic indications for an esophagram: achalasis or cardiospasm, anatomic anomalies, Barrett's esophagus, carcinoma, dysphagia, which is also difficulty in swallowing. So make sure that you kind of know all this stuff. You're familiar with it. So make sure that you go back and review pathology as you review everything else as well. So esophageal reflux can lead to esophagitis. So itis, inflammation. So when you get that reflux, you get that acid coming up, and then it's going to irritate your esophagus, and it's going to cause inflammation. So also esophageal varices, foreign bodies, and then Zenker's diverticulum. So once again, make sure that you review your pathologies. There won't be very many questions on pathologies, but there are a lot of things to ask when it comes to pathology questions. So make sure that you review everything so you have a good grasp of it. Upper GI preparation, so NPO for 8 hours prior. Follow the protocol wherever you're at. So you also want them not to be chewing gum, no smoking, and then always ask pregnancy, especially on patients of that age. You have a 10-day rule, and there is an elective booking policy. So that's going to be dependent on any of your clinic sites that you're at, whether they have to register or whether they're able to just come in. So make sure that you follow the protocol. Usually clinic sites have a protocol that is spelled out for you, so know where it is in case you have to refer to it. The radiographer, your responsibility: prepare the fluoro room, prepare the contrast, get the clinical history, explain the procedure to the patient so they feel comfortable with what's going on, so you feel comfortable that they know what's going on before you go get the radiologist. Make sure that everything is set up and prepared. Introduce and assist the fluoroscopist, so the radiologist. Assist the patient, so make sure that you get the pillow form, you get the barium form. You're there to assist the patient and the radiologist during the fluoroscopy. RAO esophagram. So if you're doing an esophagram and they're wanting pictures, 35 to 40 oblique position is what you're going to do. Either still pictures or fluoro pictures. If you put them for still pictures, you're going to position them as such, and this patient is going to sip and swallow, sip and swallow, sip and swallow when you make that exposure, because you need to see the barium within the esophagus. So instruct the patient, just sip and swallow while you make the exposure. Criteria: the entire esophagus demonstrated. So you want the entire esophagus demonstrated all the way down, and that's when you're going to do that sip and swallow, sip and swallow. Esophagus is midway between the spine and the heart, and that is your oblique position, that 35 to 40 oblique, okay? So make sure that you position your patient correctly. You're moving that esophagus off of the spinal column, because otherwise you're going to visualize that esophagus overlaying that spinal column, and you're not going to get an optimal picture, okay? So LAO esophagram, the entire esophagus demonstrated. The esophagus is still midway between the spine and the hilar region. So the spine is here, your hilar region right here, and then optimal exposure factor. So you're still obliquing them, moving that esophagram or the esophagus out of the way of the spine. Lateral esophagram. You are moving the patient's arms out of the way. If they're standing, make sure that they bring their arm out as much as possible, but they're still able to hold the cup and drink, sip and swallow as they're standing there, because you want to visualize the esophagus all of the way down filled with barium. True lateral position is going to place that esophagus anterior to your vertebral bodies. It's going to make a better picture. Sip and swallow when you make that exposure. You want the arms to not superimpose the esophagus. True lateral position. You can see that by the intervertebral foramen, the overlaying ribs, the well visualized vertebral bodies. AP or PA esophagram can be done either way. A PA puts the esophagus closer to the image receptor, but it may be harder for the patient to lay in that position. AP may be easier as far as getting the cup up there and having them sip and swallow. Just make sure that they're laying in a true AP or PA. Your central ray is to T5 or 6, so you're a little bit higher than a chest x-ray because you don't need the entire chest. You just need the esophagram or the esophagus, okay? So entire esophagus demonstrated, no rotation, optimal exposure factors. The patient was sipping and swallowing as it was coming down, so it is entirely filled with barium. RAO for the upper GI, 40 to 70 degree oblique. You're moving that upper GI, your area of interest, away from your spinal column. So that's why you're doing a 40 to 70 degree oblique. Central ray at L2, okay? So just a little bit above the iliac crest. The RAO for the upper GI, your entire stomach should be demonstrated. So you've got the entire stomach. They're a little close on this side, close to clipping. So make sure that you are able to visualize the entire stomach, the fundus, the body, the barium-filled distal stomach. The duodenal bulb and C-loop are in profile. So the duodenal bulb and the C-loop are not superimposed. They're in profile. You can see them. They are well visualized. Your upper GI, your PA, puts your anatomy closer to the image receptor. So no rotation, central ray to L2. So you're above your crest. You're just above your inferior angle of your ribs. So L2, a true PA position, and then that way you're going to visualize the entire stomach, and duodenum is demonstrated. So the entire stomach, duodenal bulb, duodenum right there. You can see that the patient prone, there is air in the fundus here, so we can tell that that patient is prone. The right lateral upper GI, true lateral position, central ray to L1. So you're doing an upper GI. You don't need the lower portion of it. So your central ray is higher. You're about at L1. True lateral position, you can see that your vertebral bodies are in a true lateral. Your upper GI anatomy is moved away from the spine. You're seeing the retrogastric space well demonstrated. Okay, so retrogastric space right back here is well demonstrated. The entire stomach and duodenum is demonstrated, so the entire stomach. Here's the entire stomach, the duodenum, the distal stomach, the duodenum, the duodenal bulb, the duodenum coming down. Everything is well visualized. It's not superimposed by the vertebral bodies. Your LPO upper GI, okay? So 30 to 60 degree oblique, central ray at L1. So you've not changed your central ray, you've just changed the position of your patient to be 30 or 60 degrees oblique, okay? So entire stomach and duodenum is demonstrated. Fundus is filled with barium, so you can see that there's no air. It's the fundus. The air is in the distal stomach, the pylorus, and the duodenal portion. So fill the fundus with barium in that LPO. Upper GI AP, no rotation, central ray to L1. They may tilt the table in a Trendelenburg position, just depending on what the radiologist is looking for and what the radiologist wants to see. So criteria summary: AP upper GI, the entire stomach and duodenum is demonstrated. Fundus is filled with barium in the AP supine position. Trendelenburg drops the head, so it kind of forces everything towards the diaphragm, and it will better fill that fundus with barium. So your small bowel series, you're visualizing the small bowel from the stomach through the small intestine to the ileocecal valve and the ascending colon. Okay, so it frequently follows an upper GI series, so you may do an upper GI and then fall right into a small bowel series, and it will require that oral contrast, so you may have to give them more oral contrast than what they did for the esophagram. Barium Enema or BE, lower GI series, it is to examine the large intestine. It may be a single or a double contrast. Double contrast is going to use room air to expand the colon, expand those loops within the large bowel, and give a better visualization of the large intestine from the ascending to the descending colon, air with barium. So review your anatomy here, know how it goes. By now you should all be familiar with it, that you have the cecum, and then you have the ascending colon to the right colic flexure or hepatic flexure, to the transverse colon, to the left colic flexure or the splenic flexure, the descending colon to the sigmoid colon, to the rectum, and then finally to the anal canal. So make sure that you know those, review it if you need to. Small bowel series, so we're going to the small bowel. Patient prep, NPO for 8 hours, just like the esophagram. No chewing gum, no smoking. I always ask about pregnancy. Do a complete history so you know what's going on and if you can use barium or not. So pathologic indications for a small bowel series: enteritis or gastroenteritis, neoplasm, malabsorption syndrome, ileus, either mechanical or adynamic or paralytic. Okay, so this is ileus of the small bowel. If you're not familiar with these terms, or if you're going, make sure that you go back and review all of these terms: ileus, malabsorption, neoplasm, enteritis, and gastroenteritis. Okay, pathology that you need to know. Giardiasis, Meckel's diverticulum, Whipple's disease. Make sure that you know and understand all of these, kind of review them as pathology. So this is giardiasis, so make sure that you know what it looks like on an image. Barium enema, patient preparation for a BE. Light evening meal prior to the exam. Cleansing of the bowels, cathartic, so make sure that you know what the protocol is in case somebody calls and wants to know what they need to do for their BE tomorrow. NPO after midnight, 8 hours minimum. So make sure that they're scheduled accordingly. Once again, no chewing gum, no smoking. And then they're always going to do an enema in the morning of the exam. Okay? So they may have to take some bowel cleansers, and then they're going to have to do a morning enema. So follow the protocol wherever you're at so you're familiar with it. Criteria summary for a PA projection: you want the entire small intestine demonstrated, no rotation. So this is for a small bowel, not a BE. So you're going to visualize the entire small bowel, and then you're going to have timed images. So make sure that you mark on them what time it is after completing drinking. So they're going to drink everything. You're going to take one which is an immediate. And then depending on where you're at, they may have protocol for 20-minute pictures or 30-minute pictures. Just make sure you know the protocol, and then whatever your image is in the series, make sure that you mark it. Is it 30 minutes from the immediate? Is it an hour from the immediate? So make sure that you mark those correctly. This is a PA or AP Barium Enema. Your entire large intestine is demonstrated except maybe the left colic flexure, okay? So the left colic flexure is going to sit higher because of the stomach on this side. This side has the liver, which is going to keep that right side pushed down, okay? So the transverse colon is filled with barium, no rotation, optimal exposure factors. Keep in mind, depending on your clinic site, wherever you're at, you may have to take 2 exposures to get all of the large intestine in an image, and then you're just going to send the 2 images over, okay? So RAOBE, the right colic flexure, ascending, and sigmoid colon are open, okay? So the RAO shows the right colic flexure, okay, and the sigmoid colon open. The entire large intestine is demonstrated, so make sure that you get all of the large intestine in there. Optimal exposure factors. Central ray should be at the iliac crest to include all of the important anatomy. But your RAO will open that right colic flexure, ascending, and the sigmoid colon, okay? So your LAO is going to open up the left colic flexure, descending colon will be open. The entire large intestine still needs to be imaged within this. So you can see here that they're clipping a little bit of that left colic flexure. So this may be, you may need to adjust this and go ahead and take a second picture to make sure that you have all of the intestine demonstrated in your images and send them over. So the central ray for the LAO is 1 to 2 inches above the iliac crest, where your, oops, I went the wrong way. Your RAO is at the iliac crest. So RAO at iliac crest, LAO 1 to 2 inches above the iliac crest. All right, so criteria summary for LPO and RPO, right colic flexure, ascending and rectosigmoid are open on the LPO, and then your RPO is the left colic flexure and descending colon. So you can go back up here, RAO, right colic flexure, LPO is the right colic flexure. So RAO, LPO, LAO, RPO. Make sure that you know those back and forth just in case you're not able to do RAO or LAO. You have to do an LPO or RPO. Okay? So lateral rectum, you want to see the rectosigmoid region demonstrated, no rotation, optimal exposure factors. So your patient is going to be placed laterally, and you're going to be imaging down into that rectum. Your central ray is at the level of the ASIS. ASIS. So criteria summary for a lateral decubitus, left lateral decubitus, you want the entire large intestine demonstrated, no rotation, optimal exposure factors. In a decube, you're going to see distinct lines of barium and air. Okay, so that's going to let you know that it was done in a decube position. Your right lateral, once again, the entire large intestine demonstrated, no rotation, definite lines of air fluid level within this image. That's what you're trying to see, okay? So the right lateral is the right side down, left side up, okay? And this is the left colic flexure it is higher because the liver pushes the right one down. So if we go back here, this is a left lateral. This is the left side down, right side up. The left colic flexure is higher because the liver is pushing the right one down. Okay? So criteria for AP or PA axial, AP or PA axial oblique. In case you need to do an oblique, usually it's just an AP axial sigmoid, usually. Just depends on where you're at. So you want to elongate the rectosigmoid colon, okay? So AP, your central ray is 2 inches inferior to the ASIS, and it's 30 to 40 degrees cephalic. If you're PA, your central ray is to exit the level of the ASIS, which means that the ASIS is next to the image receptor, so you have to adjust your central ray to make sure that it is exiting at the ASIS, and then you're 30 to 40 degrees caudad, okay? So AP is cephalid, PA is caudad. AP is 2 inches inferior to the ASIS, and PA is exiting at the level of the ASIS. Okay, this one here is showing an RAO axial, so you're still in that axial position. You're just slightly RAO'd because you can see here that everything is overlaying one another, and this separates it, okay? So depending on the protocol, you may have to do an RAO axial along with either AP or PA axial. So PA, AP post-evac, okay? So you're going to have the patient get off the table, go evacuate themselves as much as they can. Then they're going to come back, lay on the table, and you're going to image the entire large intestine, no rotation, and you're going to see that the intestine has shrunk down. It doesn't have all the air in it, doesn't have all the barium in it. That is going to show you that it is a post-evac, the last image when everything is done, okay? So pathologic indications, barium enema, colitis, ulcerative colitis. So these are some images of that. Diverticulum, diverticulitis, diverticula of the sigmoid colon. So make sure that you kind of know some differences in here. Know the difference between diverticulum and polyps, neoplasms or polyps. So these are neoplasms, advanced carcinoma of the colon, neoplasm, the apple core lesion, okay? So that is going to be a constricting portion within the large intestine. Volvus or intussusception, it's more common in infants, the intussusception is, and a lot of times you may have to do a BE on an infant to correct that intussusception. Hopefully they don't need surgery. So here you're seeing cecal volvulus. So make sure that you review these terms, review your pathology if need to. So MBS, modified barium swallow. I'm going to stop right here and I'll come back and we'll pick this one up for the next one, okay?